So our next topic is we're going to look at the metabolic changes in mom during pregnancy, and it's considerable, right? And we've sort of talked a little bit about how metabolism increases, but we're going to look a little bit more at the details of the changes in metabolism. So there are major alterations in the metabolic processes during pregnancy, and these adaptations are really directed towards four different things. So there's number one, the growth of the fetus. Okay? So the growth of the fetus is number one, which is a huge metabolic task. There's the task of building the fetal energy stores for extrauterine life. So that means that not only do you have to build an entire baby, right? You also then have to equip that baby with fat stores, so subcutaneous fat, other forms of fat that we'll talk about that's important for temperature regulation. The baby also has to load its liver and kidneys with glycogen, right, which is going to be important for the baby to be able to regulate its own blood glucose once it gets out of mom. So there's the metabolic need of building fetal energy stores. Mom also has considerable energy needs. She has to meet the energetic demands of pregnancy, right? Which we already talked about. It's about 80,000 calories, right, of the energetic demands of pregnancy. And then in addition to that, mom also has to build enough energy stores for post-pregnancy, so for labor and delivery, and also for lactation immediately after. So there are considerable metabolic needs for both mom and for baby, and these needs are actually in direct opposition. Okay? So they're actually competing with one another. So the adaptations in the maternal physiology, metabolic physiology, actually have to satisfy the needs of both mom and baby. So if we look at the sort of metabolic net effect or net state of mom and baby during two critical periods of pregnancy. Early pregnancy, meaning the first 20 weeks or so, 25 weeks or so, and late pregnancy being the latter part of pregnancy. Because metabolically, early and late pregnancy, mom undergoes a significant shift. Okay? So mom in the early pregnancy, she's in a net state of an anabolic state. So anabolism or an anabolic metabolic state means that you have a net energy storage. Okay? So we're either building our energy stores or we're breaking down, right? So anabolism is building our energy stores and catabolism is breaking them down. So in early pregnancy, mom is in a net anabolic state, which means that when she consumes food, the glucose, the triglycerides, and the free fatty acids are getting, she's squirreling all of that away. So she's building up her glycogen stores in her liver and in her muscle. She's building up her fat stores in her fat tissue. Okay? And the fetus is also in an anabolic state. In fact, the fetus is never out of an anabolic state throughout pregnancy. Okay? It's going to be building its energy stores constantly. Now, mom, however, in the late pregnancy, she switches from a net anabolic state to a net catabolic state. So she's no longer building her energy stores. In fact, she's using her energy stores during this late pregnancy. So she is using her stored glucose. She's using her stored fat. Okay? And she's using those stores for energy because the glucose that she takes in late pregnancy, she needs to take some of it, but she needs to actually make most of it available for baby. right? Because it's in this this later part of pregnancy that baby is obviously bigger, so its glucose needs are much greater, but also the baby's brain is at this important accelerated rate of expansion, and there's a high glucose demand for that. And then all of the baby is building its fat stores and it's building its glycogen stores, which also it uses it does that by taking out glucose. Okay? So in the late part of pregnancy, there's this dramatic alteration in mom's metabolism that allows her to use her stored energy and free up much of her blood glucose for baby. Okay? So really mom undergoes two segments of metabolic adaptation. The early pregnancy adaptation is geared towards energy storage, and the late pregnancy adaptation is geared towards breaking down energy stores and making blood glucose available to baby. Okay. So as you can see, the overall basal metabolic rate, so this is what we're looking at here. We're looking at the overall basal metabolic rate of mom, okay, pregnant mom, over the course of pregnancy. Now what we see is that basal metabolic rate is increasing slowly, right, in the first 20 weeks or so. But you see that between 20 weeks to 40 weeks, there is a dramatic rise in basal metabolic rate. Now, an interesting thing, so obviously this BMR, basal metabolic rate, for mom is going to be sort of accounting both mom and baby, okay? And so there's an interesting thing to keep in mind that the way we actually calculate basal metabolic rate is by heat production, okay? Because as you metabolize energy substrate, fat, glucose, whatever it is, as you metabolize energy substrate, you release a significant amount of that energy in the form of heat. So the higher your metabolism is, the more heat you're producing. So you see that this late pregnancy represents for mom this very, very highly metabolic state, right? And this really reflects her catabolic period of her pregnancy, right? This is the catabolic state of her pregnancy. She is tapping into her energy stores. She is breaking that energy down and generating a lot of heat. And a lot of this heat is also coming from baby because the baby is a net heat producer. So if you know anybody who's been pregnant and had the unfortunate luck of experiencing their late pregnancy during the summer months, you can imagine how uncomfortable it would be to be generating this much heat while it's also very hot outside. And then conversely, women who experience late pregnancy during the winter months tend to be very nice and cozy because they can maintain a comfortable body temperature without actually needing to warm themselves up very much because they're generating so much heat. Okay. So we see changes in the metabolism of nearly every category of energy substrate. So the food we consume is referred to as energy substrate, so substrate for energy production. And it comes in the form of carbohydrates, proteins, and lipid. Now, we see changes in the way we metabolize all three categories of food. So in terms of carbohydrate metabolism, there are changes that occur in how the body handles glucose and responds to insulin during pregnancy. Early in pregnancy, the maternal tissue sensitivity to insulin increases. Okay? So the tissues with insulin receptors, we're talking about fat tissue, the liver, skeletal muscle. They all increase their expression of the receptors and become much more sensitive to insulin. This increases the permeability of the cells to glucose and glucose uptake. Okay. So that means that the fat cells are taking up more glucose, storing that glucose in the form of fat. Skeletal muscle is taking it up, storing it as glycogen. Liver is storing it as glycogen. And then in late pregnancy, the maternal peripheral tissue sensitivity to insulin decreases. Okay? And that allows for a greater uptake of glucose by the fetus. So the insulin sensitivity in late pregnancy flips and starts to actually decrease. Mom actually starts to become insulin resistant to a certain degree. That reduces the uptake of glucose by her tissue, okay, and sort of encourages her to use that stored fat and glycogen for energy. And then in terms of protein metabolism, during pregnancy, the maternal plasma amino acid level and protein levels decrease. Okay? And that's because the placenta is taking up that protein and amino acid. Now, amino acids are used by the fetus to actually form glucose, that process of gluconeogenesis. And mom's plasma becomes actually lowest in the amino acids that are easiest to convert to glucose, which include alanine, threonine, glutamate, serine, and all of the other ones that I mentioned in the previous slide about mom's small intestine and the absorption. In terms of lipid metabolism, the first 2 trimesters, triglyceride synthesis and fat storage is increased, especially during weeks 10 to 13. And that increase in lipogenesis, fat production, and the suppression of lipolysis, or fat breakdown, it is mediated by that increase in insulin amount and increased insulin sensitivity. Right? So insulin levels are going up by 30%, and the sensitivity of the tissue is going up. In the 3rd trimester, mom's body is characterized by a suppression of lipogenesis and an enhancement of lipolysis, right? As mom becomes increasingly resistant to insulin, so she starts breaking down those fat stores, right, and using them for energy. So if we summarize here, we've got early pregnancy. The changes in metabolism we see are an increase in insulin sensitivity, okay, which is mostly due to estrogen and progesterone, and the increased insulin production because of hypertrophy and hyperplasia of the pancreatic beta cells, again caused by estrogen and progesterone. Maternal serum amino acid levels are declined, right, because baby's taking them up. And we see an increase of fat production with lipogenesis, less lipolysis or breakdown of maternal fat stores. Okay, so we have increased maternal fat stores in early pregnancy. Late in pregnancy, we see the tide totally shifts and insulin sensitivity declines. Okay? Now, the decline in insulin sensitivity is actually due to receptor antagonism by a very important placental hormone called HPL, which stands for human placental lactogen. Okay? It's also, we also see receptor antagonism by cortisol, right? And that's cortisol. Cortisol is coming from both mom and fetal tissue. right? That's antagonizing the insulin receptors, causing resistance. Now, mom actually continues to increase her insulin production, right? Estrogen and progesterone continue to cause this hypertrophy and hyperplasia of the beta cells and increased insulin production. Now, this insulin production, increased insulin production in late pregnancy, is actually designed to compensate for the decreased sensitivity. Okay? So we want to make glucose available for baby, but we don't want mom to be hyperglycemic. So the increased insulin production in late pregnancy is to maintain sort of normoglycemic levels in mom. There's a continued decline in amino acid levels of mom. Okay, the baby continues to take up those amino acids, and mom actually starts to break down stored fat, okay, and use that as a primary energy source as opposed to plasma glucose. And maternal glucose levels are maintained at normal levels, right? So that she's got enough for her central nervous system. And it's the increased insulin production that overcomes the pregnancy-induced insulin resistance to achieve those normal levels. Now, we talked about this in pathophysiology before, the condition of gestational diabetes, that if mom's, in this late part of pregnancy, if mom's pancreatic beta cells can't produce insulin levels high enough to overcome this insulin resistance, okay, that is normal for late pregnancy, then you get a condition called gestational diabetes, which is the appearance of hyperglycemia during pregnancy that then resolves once the baby and the placenta are delivered. Okay. So we're going to talk more about gestational diabetes. We're going to have a presentation about it, but just keep in mind that hyperglycemia is not normal for mom. She will maintain normal glycemic levels by producing more insulin. Okay? And if she can't produce that increased insulin, the result is gestational diabetes. Okay? And the reason why gestational diabetes resolves itself with the delivery of the placenta is that upon delivery of the placenta, you get rid of the source of the insulin resistance, which is human placental lactogen. Okay. So, because of all these alterations, okay, mom's metabolic control in terms of her absorptive state and her post-absorptive state are slightly different, right? In fact, it's more than slightly different. We describe the absorptive state in mom as being a time of facilitated anabolism, okay? So during an absorptive state for mom, when she's consuming food, she is in a state of relative hyperinsulinemia. She's in a state of hyperglycemia, okay? So that means that when she's consuming food and absorbing food, her insulin levels are higher than pre-pregnancy. Her glucose levels reach a higher state than they did during the absorptive state of pre-pregnancy. She has hypertriglyceridemia, so her triglyceride levels are higher, and she has a greater rate of fat production. Okay. And then in her post-absorptive state, after she's finished consuming food and then an hour or two later, she's actually in a state of what we describe as accelerated starvation. So the maternal responses to fasting are actually accelerated or exaggerated. And it's exaggerated because of a continuous placental uptake of glucose and amino acids. So now it's not just mom's tissue that's taking up glucose, it's baby and placenta that's taking it up. A decreased peripheral utilization of glucose, decreased renal reabsorption of glucose, and decreased hepatic production of glucose. So during a post-absorptive state, mom's glucose level is going to get lower than it would in a post-absorptive state pre-pregnancy, so a relative hypoglycemia. Her ketone level is going to get higher because she's breaking down fat instead of glucose. Her amino acid levels are going to get lower because baby's taking that up, but her insulin levels remain higher than it would in a pre-pregnancy state. Okay. So during pregnancy, bottom line is the conditions of the absorptive state are really magnified and exaggerated, and the conditions of the post-absorptive state are also magnified. And then if we think about early versus late pregnancy, in early pregnancy, when mom is already in an anabolic state, this absorptive state is going to be even more exaggerated. And then in late pregnancy, when mom's already in a catabolic state, this post-absorptive state is going to be even more exaggerated.